The spinal cord is a complex part of the central nervous system, relaying both sensory and motor information between the body and brain, as well as connecting a large part of the peripheral nervous system. It has the ability to integrate and modify both afferent signals and efferent signals. So what happens when this production line of communicating neurons gets disrupted? Acute spinal cord injury occurs with trauma to the spine, most commonly causing dysfunction and impairment of both motor and sensory function as a consequence of vehicle accidents, sports-related injuries, falls, and violence. Spinal cord injuries, as a general, can be divided into 4 subtypes: cord maceration, where morphology is disrupted; cord lacerations; contusion, usually leading to central hematomegalia, a hemorrhage; and solid cord injury, costing society in excess of approximately $7 billion annually. Acute spinal cord injury is one of the first of 3 potential phases post-injury, having an estimated 50 to 20 cases per million in annual incidence worldwide. Most commonly expressed as a compressive contusive injury, where both displaced vertebra and intervertebral ligaments exert sustained force on the spinal cord. Upon impact, damage immediately affects neural and soft tissue, inclusive of endothelial cells within vasculature, usually resulting in necrosis and cell death, predominant in the grey matter particularly. Following the instant injury, a cascade of action potentials cause electrolytic shifts of intra and extracellular concentrations, causing toxicity and a state of spinal shock and dysfunction of neural homeostasis and ionic dysregulation with calcium. The acute phase is the phase most likely to amend the following conditions with neuroprotective interventions if identified and sought early enough: inflammation, increasing edema, hemorrhage, immune-associated neurotoxicity, and glutamate-mediated excitotoxicity. Recent advancements in pharmaceuticals and other physical therapies are constantly emerging. Methylprednisolone, the most studied drug in spinal cord injury, is used to treat acute, particularly targeting inflammation and reduction of edema. The family of corticosteroids in general have been used in neurotrauma for decades, revealing improvements in spinal cord blood flow, reduced calcium influx, and attenuated lipid peroxidation. Methylprednisolone is a glucocorticosteroid with antioxidant properties, and according to the National Acute Spinal Cord Injury Study post-hoc analysis of methylprednisolone sodium succinate, when given a high dosage within 8 hours of injury, reveals promise with improved clinical results. Patients who received the drug 3 to 8 hours post-injury exhibited improved neurological function 6 weeks and 6 months post-injury, when given it for 48 hours. However, with such high dosage, the study did find out that patients were twice as likely to have severe pneumonia and 4 times severe sepsis, also risking death with a 6 times higher incident rate in the 48-hour group study than in the 24-hour infusion group. Lazeroid, however, is a new potent inhibitor of lipid peroxidation without glucocorticosteroids, posing fewer side effects. Therefore, methylprednisolone is recommended as an option, and rather only to be undertaken in the knowledge that the harmful side effects outweigh clinical benefit. As a result of injury, damage to nerve and cell myelin results in loss of efficient conduction. Therefore, there has been a focus on cell replacement strategies, testing multiple cell types and tissues to replace this function loss. Stem cells, olfactory unsheathing cells, oligodendrocytes, and Schwann cells are just among the few with promising success. Exogenous neurotrophins have been useful in restoring cells that have lost their neurotrophic support as a result of projection, neuron, and oligodendrocyte death. Neurotrophins such as fibroblastic growth factor regulate a broad spectrum of biological functions, regulating cell proliferation, survival, migration, and differentiation, and therefore is a promising therapy for acute spinal cord injury once collagen production is controlled for and tumorigenic potential, things not normally found in the spinal cord. Spinal decompression is a form of traction used to create space and promote regeneration within the intervertebral space of spinal vertebrae by creating negative pressure within. Its aim is to relieve pressure of the spinal cord, decrease stenosis, radiculopathies, and retract as much as possible herniated and bulging discs as a result of injury. The patient is strapped in by 2 belts, a lumbar pulling from the bottom and a thoracic holding the patient up. Traction targeted to the disc by angling the table upwards to a certain degree of focus. Treatment is specified for each individual by weight, height, and MRI scans. A cohort study conducted on 30 patients also revealed relief of pain from a rating of 6.2 to 1.6 post-therapy. Additionally, a retrospective cohort study evaluated neurological improvement was most favorable when decompression was used within 8 hours of injury. Therapy can initially be a bit painful with the pressure applied, but yields promise, an improvement of mobility and pain. The alternative is not more damage, rather potentially too severe a case to yield a great deal of improvement to patient satisfaction, but improvement nonetheless. It's a timely process that usually requires multiple sessions for 4 to 12 weeks. With the ever progressing advancements of science, future treatment options only broaden. Rehab programs should be focused on all aspects of motor control, more research into selective inhibition interventions. Considered apoptotic death requires de novo protein synthesis and is dependent on energy. Perhaps an engineered cell could surpass these obstacles to optimize regenerations of cells after necrosis. Altering secretory products of transplanted cells should also be a focus moving ahead.